Hospital Stroke Center and section leader in teleneurology. Dr. Man completed her residency and her PhD in China Medical University. She completed vascular neurology fellowship at Cleveland Clinic, neurology residence at Wayne State Medical School. She's a board certified in neurology. Welcome, Dr. Man.
Thank you for staying late through the conference. It's such an honor to speak at the same session with Dr. Shrip. Dr. Shrip has highlighted the global aspect of disparity in terms of stroke risk factor management. Today, I will just focus on the acute stroke treatment part in the United States. So we'll talk about the racial ethnic disparity in acute stroke treatment in the United States. And then we will talk about the geographic disparity, mainly rural-urban disparity. And then mainly focus on the actionable disparities and the future directions. So what do we know about racial ethnic disparity in stroke care? We know that racial and ethnic minority patients are 20% less likely to receive thrombolytic treatment than white patients. This is among all the ischemic stroke patients without considering the time of presentation. And Black and Hispanic patients are more likely to experience incomplete stroke recovery and experience more disability after stroke. So the question is, are these disparity come from delayed presentation, meaning racial and ethnic minority patients are less likely to arrive at the hospital within the 4.5-hour window, or because the hospitals, our care providers are not providing the equitable treatment, even if they are in the hospital already. So we use the National Gateway Guideline database. We calculated the arrival time, the proportion of patients arrive within 4.5 hours among all ischemic stroke patients. And we found that there's no disparity in terms of the delay. Oh, sorry. We found that in terms of delayed arrival, Black and Asian and Hispanic patients are more likely to arrive at the hospital within beyond the 4.5-hour window. And this pattern persisted after adjusting for the patient and hospital characteristics. And then we dissected the time of delayed arrival into delayed 911 activation or delayed EMS transportation. And we found that in terms of 911 activation, Black patients are more likely to activate 911 after the 3.5-hour window, which gives them less time to arrive at the hospital within the 4.5-hour window. And when we count the time of EMS transportation from 911 call to hospital arrival, we found that the patients, Black, Asian, and Hispanic patients, actually arrive at the hospital sooner than the white patients. And then we look at the patients who arrived within 4.5 hours in the hospital. And we found that Black and Hispanic patients are younger than the white patients, 10 years younger, and they are more likely to have no insurance. than white patients. And actually, the arrival by EMS rate are quite similar. And then we look at the thrombolysis rate and door-to-needle times. We found that there's no disparity in terms of receiving thrombolytic treatment if the patient arrived within 4.5 hours. And when we look at door-to-needle time within 30 minutes and 45 minutes and 60 minutes, those guideline recommended time frames, we also did not find disparity just by the gross quality report rate. And then we adjusted for patient and hospital characteristics, including NH stroke scale. Then we noticed that there is still disparity, that Black, Asian, and Hispanic patients are less likely to receive thrombolytic treatment within the 4.5 hours. And so to summarize this part, the national improvement initiatives are associated with continuous improvement in thrombolytic treatment for all race and ethnic groups. And racial and ethnic disparity were not evident in unadjusted quality metrics, but emerged after adjusting for hospital and patient characteristics, including stroke severity. And Black, Asian, and Hispanic patients were more likely to arrive after the 4.5-hour thrombolytic time window. And this was mainly due to the delayed 911 activation rather than the EMS transportation. So future direction on this is to further conduct a culturally tailored pre-hospital community stroke education and stroke readiness. This is what we have been doing in Cleveland Clinic and nationally. There has been some national studies on this in Michigan and also California and DC, but the effects were quite small, mainly because the scale is smaller, and it's hard to measure the actual thrombolytic rates among other community patients. And then next, we looked at the rural-urban disparity. The fact of rural America is that 97% of the U.S. landmass are rural, and it's a home for 66 million people, and cared by 1,800 rural hospitals, small and rural hospitals. The rural-urban disparity is more on the crisis level, that stroke incidence and mortality are 30% higher in rural communities. And the rural patients, among all rural stroke patients, they are 50% less likely to be treated with thrombolytic treatment. The question is, are the rural-urban disparity caused by delayed arrival because there are a longer transportation time, the rural patients live further away from the hospital, or because the hospitals are not providing the equitable care? So this is the work done by our fellow Sadat Go. He used the national EMS database, and he found that among all ischemic stroke patients, when we compare with urban white patients, there's really, in terms of arrival beyond the 4.5 hours, only among the rural Black patients that we found there's delayed arrival and delayed 911 activation. among other rural patients, Asian, Hispanic patients, we did not find the delayed arrival, significantly delayed arrival, or delayed 911 activation. On the other hand, when we looked into the call to the stroke onset to 911 call time, we didn't, when we look at the call to scene time, from 911 activation to hospital arrival, we've found significant differences that rural patients, regardless of race and ethnicity, they experience longer call to scene arrival time and delays in call to hospital arrival. And then we look at the rural hospital performance. Here's the majority of the disparity come from. And so when we look at Gateway Guideline database, among urban hospitals, among those who arrived within 4.5 hours, almost 45%, close to 50% of patients received the thrombolytic treatment. But in rural hospitals, in rural stroke centers, that rate decreased to about 30%, and that rate further decreased to 22% among rural non-stroke centers, which is the majority of rural hospitals. They are small and not certified for stroke care. And when we look at the rate of thrombolytic treatment within the 45 minutes outdoor to needle time, that rate was 50% in urban hospitals, meaning that 50% of patients in urban hospitals who are treated with thrombolytic treatment received the treatment within 45 minutes. And that rate decreased to 1 in 3 patients in rural stroke centers and 1 to 4 patients in rural non-stroke centers. And rural non-stroke centers also provided less secondary stroke prevention and had higher in-hospital mortality. And we looked at the post-acute care after ischemic stroke in rural hospitals. We found that in terms of acute inpatient rehab, there's a 5% absolute difference in the chance of patient being discharged to acute inpatient rehab in rural hospitals compared to urban hospitals. And that difference is reflected in the higher chance of being discharged to skilled nursing facility. So more patients were discharged to nursing home rather than acute rehab in rural areas. And this is adjusted analysis that fortunately we did not see the difference in overall mortality in rural and urban hospitals, knowing that many rural hospitals transferred sick patients out. So that can be, should be considered. But we did find that rural patients have less home time. They spend less time at home after stroke and more time in the facility. There's a paradoxical effect that rural patients have lower readmission rates, perhaps because they don't have as much access to acute care, so they choose to stay at home when they need it. So to summarize, rural patients experience longer EMS response and transportation times. Rural hospitals provide lesser evidence-based stroke care, and including secondary stroke prevention. Rural Black individuals, just like urban Black individuals, experience more delayed 911 activation. So the future direction of rural-urban disparity should focus on improving the rural hospital acute treatment and post-acute care. And Also, the racial and culturally tailored acute stroke readiness should happen in both rural and urban communities. Last but not least, I want to thank everyone that helped me in this research. And thank you for listening.
Thank you, Dr. Man, so much. Estelle, I have one question for you. So did you come up across of any data about using telestroke in the rural area? Did it really improve the performance there, or there's no data about this?
Yes, there has been data about it. There's this data from several centers, Emory, University of Emory and Mayo Clinic. They all found that telestroke treatment in rural areas improved the utilization of thrombolytic therapy and also improved the door-to-needle times.
Okay, good. So we may have to extend
Yeah.
the telestroke program.
Yes.
Thank you. Thank you, Dr. Man.